Dr. Mahmoud, ladies and gentlemen, it's a great pleasure to talk to you today. I'm only sorry I cannot be there with you. Shukran for the invitation to talk at this meeting, the Pan-Arab Conference. We are now 100 years after insulin was discovered, and I'm going to put it to you in the course of this talk that we know so much more about type 1 diabetes, the type of diabetes that saved this boy's life. But we also know that he is not a typical case of type 1 diabetes. And I will explain that in the course of this talk. Type 1 diabetes, as I'm going to present it to you, is a disease with great heterogeneity due to gene-environment interaction, due to an age effect, and the implications of those two are that the treatment of this disease is also likely to be different. One way of envisaging this disease is the interaction of genes and the environment. In the threshold hypothesis, these two interact to such a degree that they cause the disease. Sometimes the genes being stronger than the environment, other times the environment being stronger than the genes. But there are genes, genetic mutations, which by themselves can cause the disease, as highlighted here for FOXP3 mutations and AIRE mutations, which of themselves can cause type 1 diabetes. This is obviously a purely genetic form. In contrast, on the right is a typical environmental effect due to the rat poison Vacor, which can damage the beta cells, or due to pancreatectomy, just removing the pancreas, which of course can cause type 1 insulin-dependent diabetes. So there are many different types, and in general, these types are involved both genes and the environment in causing classic type 1 diabetes. Now, here is the incidence of the disease as we understand it, rising, as we know, to a peak incidence between the ages of 10 and 15, which made us always think that type 1 diabetes was typically a disease of childhood. Now, we know that in those people who are under the age of 13, particularly under the age of 7, there tends to be multiple autoantibodies which are associated with the disease, with a marked loss of insulin requiring immediate insulin therapy. And these people tend typically to have an HLA genetics association with DR4 and DQ8. Twin studies suggest that the disease at this age has a very high heritability. Now, in contrast, if we look at people who are over the age of 13, often they have just single autoantibodies, invariably to glutamic acid decarboxylase, or GADA. Their insulin levels may be low, but they're not necessarily absent, and they are often not necessarily on insulin for therapy. Further, their HLA type tends to be DR3 and DQ2, not DR4 and DQ8, as in the younger individuals. They have been associated with type 2 genes, but I'm not going to mention that further. And they are, in twin studies, known to have a low heritability. However, the condition is more complex than that, because that suggests heterogeneity. But in fact, in those young individuals, often it's a mixture of effects with insulin autoantibodies and that DR4, DQ8 genetic association, but also often the GADA antibodies and the DR3, DQ2. So multiple autoantibodies are very much a feature of younger children with type 1 diabetes. But the older people certainly seem in the main to have single autoantibodies with this lower heritability and a reduced risk for insulin dependence. Surprisingly, I'm going to put it to you that the incidence of adult onset type 1 diabetes, and I mean here the classic type 1 diabetes, is higher in adults than in children. Now, this comes from different sources in Europe, in America, and China. For example, in Sweden, those people who are aged under 20 have an incidence of 37.8 per 100,000 per year. And those who are older have a lower incidence. But of course, those who are younger only have 2 decades of the disease, whereas that older group are operating over 8 decades, 80 years. And the result is that 74% of people with type 1 diabetes in Sweden present in adult life over the age of 20. The same is true in America. Again, a higher incidence in people under 20 than in those over 20, but again, because the duration of the effect is longer in the adults, in some 59% of people with classic type 1 diabetes present over the age of 20. And in China, a much lower incidence than it is in Europe or North America, much, much lower, but again, higher in children than adults. And indeed, 65% of Chinese people with classic type 1 diabetes present over the age of 20. So we can conclude that adult onset type 1 diabetes is indeed more prevalent than childhood onset disease. And I'm not even considering here those people who have adult onset autoimmune diabetes, which is not initially insulin requiring, which some of you may know as LADA, or latent autoimmune diabetes of adults. Now, the same is true of heritability, that there is a variation in the degree of heritability according to the age at onset. Here are the 3 major twin studies that have been performed in America, in the United Kingdom, and in Finland. And in all 3, those who are younger onset have a higher concordance rate, that is, both twins affected, than those who are older, irrespective of what age you take the cutoff, whether it's 25, 15 years of age, or 10 years of age. Notice that in those who are over 25 years of age in the joint American-British study, only 6% were concordant for type 1 diabetes. In the Finnish study, those who were over 10, it was 23%. So it looks like there's a much stronger genetic effect in the younger onset group than in the older onset people. C-peptide also shows a variation where C-peptide is a proxy for the amount of insulin you produce. This is an important Scottish study from a large cohort where they looked at the plasma C-peptide according to your age at onset and your disease duration for several thousand individuals with type 1 diabetes. Those people who have levels over 20 picomoles per mil are shown in blue, and those who have lower levels are shown in pink. What you can see here is that those people who are young, that is under the age of 10 at diagnosis, tend to be pink, and they fall rapidly with disease duration. Those who are older tend to be blue, that is their higher C-peptide. They also fall with time, but they fall more slowly. But I also want to point out that there is no clear separation between those who are young and those who are old. It appears to be a continuum. So there is heterogeneity, but without clear distinction between one group and the other. This is true also for other features within the islet itself. We know, for example, that proinsulin, which is the precursor hormone of insulin, is secreted in increased amounts in people at risk of type 1 diabetes. In particular, the pro-insulin C-peptide ratio can be increased compared with controls. But look at that ratio here, according to those diagnosed under the age of 7 and those diagnosed over the age of 13. Observe how those people who are younger have a much higher pro-insulin to C-peptide ratio than those who are over 13. And this may well reflect a form of beta cell stress associated with endoplasmic reticular stress. Now, it's also true that those who are under the age of 7 have different insulitis. They have much greater insulitis in their pancreas with greater infiltration of T lymphocytes, for example, but also of B lymphocytes, CD20 high cells, compared to those who are over 13 years of age. So there is this clear distinction between these two groups, but you will see, as for C-peptide, that the pro-insulin C-peptide ratio can be high in those who are over 13. So again, there is not a clear categorical distinction between the groups, just a suggestion of heterogeneity across the age ranges. That heterogeneity and the implications that there may be mild forms of glucose intolerance in those at risk are illustrated by this old paper from the diabetes prevention trial, which found that abnormal glucose tolerance could be found in relatives of type 1 diabetic patients who had protective HLA alleles, notably that 0602 allele, which is quite strongly protective against developing type 1 diabetes. And yet these people who are not diabetic do have abnormal glucose tolerance. So I see diabetes as a spectrum, not really binned into young and old, but rather a variation across the age ranges, so that with increasing age, there's decreasing HLA genetic susceptibility, a decreasing risk for autoantibodies, an increased tendency to have C-peptide, and a decreasing tendency to require insulin treatment. And all of these features, apart from autoantibodies, extends into non-insulin dependent type 2 diabetes in adults. But autoantibodies do seem to distinguish those who have type 1 diabetes from those who do not. That is to say, if those autoantibodies are clearly diagnostic of the disease, which they may not be. So here is heterogeneity exhibited before the onset of diabetes, where those people who have 3 autoantibodies, shown in the dotted lines, develop the disease more rapidly up to the age of 20, displayed on the horizontal axis, with the proportion remaining without type 1 diabetes on the horizontal axis. Those who have only 1 or no autoantibodies do not go on to develop diabetes to that degree. So having multiple autoantibodies, even before the disease, is associated with a more rapid regression to clinical type 1 diabetes. You can see that in that age effect in as illustrated here, so that those who have even multiple autoantibodies, that is at least 2 shown on the left in table A, figure A, or more than 2 autoantibodies shown on the right, figure B, those people who are under the age of 12 are shown in red, and those who are over the age of 12 in blue in both figures. And the percentage who do not have diabetes is shown in both cases on the vertical axis, with their time from detecting multiple autoantibodies on the horizontal axis. Now, even in these cohorts who have multiple autoantibodies, age is important. So that in the illustrated on the left, up 10 years after the onset of multiple autoantibodies, still in those who are under 12, 50% have not developed the disease, but they certainly are developing the disease more rapidly than those who are over the age of 12. That distinction is even more apparent in the right, where there are multiple autoantibodies, more than 2 autoantibodies, where again, the people under the age of 12 in red are developing the disease more rapidly than those who are over the age of 12, shown in blue. So something is happening here, and let's move into a different age range, into adult onset diabetes, where people who present, as here, to Swedish clinics with adult onset diabetes were identified in 5 different clusters. And I'm going to concern ourselves here only with 2 of these clusters, which represent about 1/4 of all these cases of adult onset diabetes. These 2 clusters, cluster 1 and cluster 2, are characterized by the fact that on presentation, they had non-insulin requiring diabetes. And the only difference between the 2 is the fact that cluster 1 has GAD antibodies and cluster 2 does not. But look at the rest of the features. In both cases, they have low C-peptide. Their body mass index is low, they're not obese. Their HbA1, their average glucose at presentation, is high. They tend to be younger than the rest of the cohort of adult onset diabetic patients. And they often present in diabetic ketoacidosis, or more often present than is the generality of the case. Now, what is it about these 2 cases? Well, if you look here at the HbA1, you will see that in both of them, the HbA1, shown here on the vertical axis against duration of diabetes on the horizontal axis up to 8 years, HbA1 is extremely high in these 2 clusters, falls dramatically with therapy, but remains elevated throughout the next 8 years. Now, cluster 2 would be seen as typical type 2 diabetes. Cluster 1 is this group, which some of you know as latent autoimmune diabetes of adults. I like to call them adult onset autoimmune diabetes because I don't like this LADA term. But they are effectively a form of type 1 diabetes, but simply they do not require insulin initially, but we are not treating them properly. And that's important. And it turns out that even when we give them insulin, we're not treating them properly because they still tend to have a high HbA1. So what is the value of classifying diabetes and of identifying those people at young age and old age according to the nature of the diabetes that they have, even within the context of type 1 diabetes? Well, it will guide your decision-making in terms of their natural history. Those people who have type 1 diabetes, even if they don't present as requiring insulin, will have a different natural history, a more rapid course than those who do not, who are type 2 diabetes. You've seen how the HbA1, and it's true of hypos as well, of severe hypos, you've seen how the HbA1 tends to be increased. The frequency of poor glucose control is increased in type 1 diabetes. Of course, they have other autoimmune diseases, particularly as adults. They're at risk, for example, about 1/3 of them have thyroid autoimmunity, and this should be sought not only in them, but also in their relatives. And finally, you must think about their therapy. For example, if we're going to use immune therapy, we know now that there are different immune therapies which work in people with HLA-DR4, such as teplizumab, anti-CD3, compared to those with HLA-DR3. And this may also be relevant in terms of the sort of treatment we give them when they're adults. So it's very important that we start thinking about precision medicine and the classification even of type 1 diabetes. So finally, I have presented you with evidence that there is a heterogeneity across the range of type 1 diabetes. That heterogeneity represents different degrees of an gene-environment interaction, and it is highlighted by an age effect, but within that age effect, there are other factors, including genetic differences, metabolic differences, and immune differences. And in time and in turn, these changes will be represented by a different approach to our treatment of these forms of type 1 diabetes. Shukran and masalam.